right. If you guys have watched these 3 lectures back to back, I hope you're not too googly-eyed. So if you need to take a break, I highly suggest it. One more lecture. This one shouldn't be too bad. We're talking about maternal history and factors determining the high-risk infant. So we're going to talk about, what could go wrong after the mom finds out that she is expecting, or even before she finds out. So objectives, we're going to talk about components of maternal medical history, things that you're going to see in the chart. Okay, we're going to talk about some specific descriptors, stuff like that. Identify high-risk maternal and medical and social issues may resulting in a high-risk pregnancy. Discuss the role of prenatal care, how important it is in identifying and reducing complications. We're going to talk about the terms gravida and parity, okay, and how those relate to, hold on a second, I'm going to turn my video off because it's blinking, so sorry about that. How gravida and parity are used when we're talking about prenatal report. List infections that can impact maternal health and perinatal transmission. Explain risk developing premature rupture of membranes. Okay, what can happen if the amniotic sac breaks early or is leaking? We're going to describe 2 specific placental level events called placenta previa and placental abruption and how they affect the fetus and if they are medical emergencies or not. And we're going to differentiate between preeclampsia and eclampsia and explain the differences between pre-gestational and gestational diabetes. We're also going to talk about complications common to infants of a diabetic mother. Define the terms poly and oligohydramnios and the disorders associated with those. Identify indications for antepartum fetal monitoring. Talk about stress and non-stress tests. Explain ultrasounds. We're going to show, look at different examples of different kinds of ultrasounds and how detailed they are. Recognize risk factors for high-risk pregnancy and delivery. Talk about some medications used to stop preterm uterine contractions and discuss the risk to fetus when a pregnancy is post-term. So let's get into a little bit of these nitty-gritty details. This is mostly chapter 2. There's a table that 2-3 that gives a very detailed list of high risk, not necessarily behaviors, but reasons that a mom might be high risk. But there's lots and lots of different reasons. So many reasons for lack of prenatal care. Okay, so that the first maternal risk factor is lack of prenatal care. And there might be a lot of reasons for that. It's a better way to say it. The big one, I hope you guys are all thinking is cost. Okay, so a lot of people will say, I got no prenatal care because I don't have insurance or I don't have the resources to get the prenatal care, which is really sad in this day and age because there are free resources out there. Some people just don't know where to find them or how to get the right assistance. So prenatal care is super important. Monitoring, nutrition, all of those things that are involved in prenatal care. But if you don't have it, it could put your baby at risk. Maternal age. Now, I will tell you that I know that the age of women having children is getting older and older, okay? We are in a time that women want to have their careers before they want to have their kids. For medicine, okay? I'm not talking about out of the realm of possibility, but in medical terms, if you are less than the age of 16 when you are pregnant or over the age of 40 when you are pregnant, those are considered high risk. Okay, they are considered high risk at under the age of 16 because some girls are still growing and developing at that point. Okay, so they haven't necessarily even been completely through puberty. And then you throw in growing a baby into your normal developing physiology, it complicates the issue. every girl matures at different rates. Some start menstruating at age 11, some are mature by age 15. Some don't start menstruating until age 15, and it takes a couple of years for that transition. So it just depends on the person. So maternal age less than 16 is considered high risk. Over the age of 40, okay, so I fall way into this category. The bottom line is women are born with the total number of eggs that they're ever going to have. And the older those eggs get, the more chance of pregnancy problems that you will have. There's a higher risk of birth defects and genetic problems with quote unquote old eggs. So maternal age weighs in. If you're less than 16 or over the age of 40, you have a higher chance of having complicated pregnancies. Mid-20s, early 30s are the best and safest time in your life to have babies. Another common risk factor is fetal weight. This is why we do ultrasounds that will give us an estimate of what the baby's weight is. Okay, we know, as we talked about in development of the lungs, development of heart, we know where those milestones should lie. We know at a specific gestational age about how big that baby should be, about what their weight should be or their measurements should be. So if that baby is not growing at a normal rate, they may be considered small for gestational age. Okay, so we base everything on a normalized gestational chart. What should that baby look like at a specific week gestation? If they're small for gestational age, that might mean they have a lack of nutrition, or maybe they are not absorbing the nutritional material correctly. Maybe their body's physiology isn't working correctly. If they are large for gestational age, okay, this could be an indication of the mom having diabetes. Or if the mom has diabetes, whether it's gestational or not, it can cause a baby to be large for gestational age. Normal babies at birth are 6 to 8 pounds. That's just kind of normal. Okay, but we're going to look at a chart in the upcoming slides that kind of show gestational age and what our normal values are. Low socioeconomic status. Okay, this is not to point out any group, but it goes hand in hand with poor prenatal care and poor nutrition. Okay, so if you have a lower socioeconomic status and you can't get resources or don't know what resources to look for, your nutrition is usually poor, you don't have your prenatal vitamins to support your body being stressed of a pregnancy, and it could cause issues. And then gestational diabetes, and we're going to dive a little deeper into that. But every single mom receiving prenatal care is tested for gestational diabetes. Infants of diabetic moms get excess glucose because that glucose that the mom is not processing is dumped into the bloodstream. That blood is taken to the baby, okay? Through the placenta, glucose travels into the fetal circulation. It goes to the baby and it's basically stored as fat. So that baby's may be very large, have a lot of adipose tissue or a lot of fat tissue. And as they grow, the physician's looking at that baby and saying, this baby's huge. Even though it's not term gestation, we need to deliver the baby because it's so big. So these babies are large babies, but they often have underdeveloped lungs. So then they have pulmonary problems. So that's where that gestational diabetes, infant of diabetic mother, that's where that comes in. You have very large babies with underdeveloped lungs, and they usually have respiratory issues. So here's that list of maternal risk factors. Not a conclusive list, but one of the other high risk areas is preeclampsia. Okay, so preeclampsia, part of it is hypertension. Someone with chronic hypertension has a high risk of developing worse hypertension. If that happens, then you could essentially reject the baby. The other thing that can happen is if your blood pressure is so high, it could cause a stroke in the mom. So maternal risk factors for developing preeclampsia: chronic hypertension. If you had a prior pregnancy with preeclampsia already, then they watch you very, very closely. It doesn't mean you're going to have it again, but they watch you closely for that to reoccur. First pregnancies, just because it's an unknown if you have any history of it. Extremely young maternal age or advanced maternal age, so that's that under 16 over age of 40. Multi-fetal pregnancies, so twins, triplets, quadruplets, have a higher chance of preeclampsia. Patients with diabetes, patients that are extremely obese, patients with connective tissue disorder or chronic renal disease. Okay, so preeclampsia, I guess I didn't even define it, but it's chronic hypertension unique to pregnancy. Okay, so the mother develops elevated blood pressure and is dumping protein into her urine or proteinuria after the 20th week of pregnancy. Okay, blood pressures associated with preeclampsia are generally systolic of greater than 140 and diastolic greater than 90, so it's registering above the normal limits. If it's not treated and the patient or not identified, they can have severe headache, blurred vision, stomach pain, irritability, excessive weight gain or swelling. Okay, this can lead to fetal morbidity and mortality. It can lead to a maternal stroke. Okay, it can cause a lot of other issues. So patients are very, very closely monitored for preeclampsia. Okay, preeclampsia can progress into eclampsia. Eclampsia is defined as hypertension with the presence of seizures. Okay, so that's another thing, stroke, seizures. After other seizure disorders or causative factors have been ruled out, there's a syndrome called HELP syndrome, okay, that they look at. HELP syndrome is hemolysis, elevated liver enzymes, and low platelets. HELP presents serious morbidity and is managed similarly to preeclampsia. So they need to really watch the mom's blood pressure. They have to watch for stroke, for a liver rupture, and for cerebral hemorrhage. So it's really serious. Maternal mortality is as high as 25% if it's left untreated. So this is why pregnant women need to have regular prenatal physician visits. They monitor blood pressure, they monitor glucose, they monitor protein in your urine. All of these things will give us an indication if there's any prenatal issues going on. Now, high-risk pregnancy, diabetes. So there's different classifications of diabetes. We know type 1, type 2. Those are pretty chronic, very well controlled, easily controlled. But then there's gestational diabetes. It occurs in 2 to 9% of all pregnancies. Anybody who knows someone who's had a baby or has had a baby themselves, you've had to go in your second or third trimester, usually toward the end of second, beginning of third, and go in as a fasting, so you can't have anything to eat or drink, but then you drink this incredibly sugar-filled liquid. And then they make you wait a little while, and they'll do blood tests and urine tests to see if your levels of glucose are normal. Usually, if a patient is diagnosed with gestational diabetes, it relates more strongly to type 2 diabetes. So it's usually able to be controlled by diet. Very rarely do patients have to go on insulin or other medications. It usually goes away when you have the baby. Okay, so type 1, type 2 diabetes, those can happen anytime. Type 1, insulin dependence. Type 2, diet, exercise, sometimes oral hypoglycemic drugs. Gestational diabetes usually can be controlled by diet, and it usually goes away when the baby is born. But any of these, if left untreated, can produce a very large baby with very underdeveloped lungs, which then, creates more issues in the long run for that baby, especially at birth and post-birth. Some other high risk characteristics of the mom that may give them a higher chance of getting gestational diabetes. Specific people of specific heritage, that's what I want to say. Asian, Hispanic, African American, Native American race have a higher chance of gestational diabetes. I can't tell you why, they just do. Patients that are very obese have higher chance of gestational diabetes. Advanced maternal age, so that greater than 40. If they have a history of gestational diabetes. Now, I will tell you this isn't always true because my sister had gestational diabetes with her first and did not with her second. That's why they test all mothers. They screen them all. If you have a family history of diabetes mellitus or type 1 diabetes, previous pregnancy with an infant weight greater than 9 pounds. So even if you weren't diagnosed with gestational diabetes, there's a chance you maybe had it because you had such a large baby. And patients with polycystic ovarian disease have a higher chance of gestational diabetes because most of them are insulin resistant. And most patients with PCOS are on some type of insulin producing drug or insulin or glucose stabilizing drug type thing. Other maternal factors contributing to a high-risk pregnancy. This is that table that I was referring to. We could go through all of them, but you can go through them yourself and you can read the textbook. Chronic conditions such as asthma, hypertension, anemia, autoimmune disease, kidney, cardiac, epilepsy, obesity, all of these chronic conditions can lead to some form of a high-risk pregnancy. Doesn't mean they won't, doesn't mean they will. Okay, if any of these are controlled and monitored, then your pregnancy can be completely normal. History of past pregnancies gives us an indication of what this future pregnancy might be like. But again, not necessarily. If you had a C-section before, depending on how they did the C-section, you may have to have another one. If you had a preterm delivery before, meaning a preemie, well, then they may watch you a lot closer. They may put you on extra monitoring or have extra visits extra often. If you had a past pregnancy that was a multiple gestation, they're going to watch and make sure you aren't having another multiple gestation. Stillbirth or miscarriage in previous pregnancies, again, they will monitor you way more closely. That's same with all of these. Placenta previa, which we're going to talk about what it is. Placental abruption, going to talk about what it is. Low birth weight. This is straight from your textbook. This makes the age range even narrower. They're saying younger than 18 and older than 35. Okay, so I always went by the 16 and 40 rule, but your textbook says 18 or 35. History of infection, or if they get an infection, viral, bacterial, or STDs. Many STDs, you have to have a C-section in order to not transmit that to the baby. So it's super important to know that patient history. And then pregnancy complications, and we'll go into a lot of these, so I'm not going to go over them in detail. Here's that growth chart. So any baby, along here we have gestational age, 24 weeks to 46 weeks. I'm telling you, if I went to 46 weeks, that would be 6 weeks overdue. That would be horrific. And all my kids were overdue, all of them were. Large for gestational age is up in this area. Appropriate for gestational age falls right in the middle of the two lines. A small for gestational age falls below the line. 80% weigh within normal limits, or they're called AGA, appropriate for gestational age. Okay, so that's 80% of babies born. If they fall below the 10th percentile, so 10% or below, they are called small for gestational age. If they are 10% above the 90th percentile, then they are large for gestational age. It's just a classification. Many of the preemies, you'll see them. They're SGA, small for gestational age. So when we have a mom coming in and you know you're going to delivery, the one thing you want to really pay attention to is their history of previous births and pregnancies. It can give you a clue as to what to expect from subsequent births. For example, if they had a C-section before, once you have a C-section, it's rare for an OB to let you do a VBAC or vaginal birth after cesarean. Okay, there are some that will let you do it, but they will also say, you can try, but if I see any evidence of uterine rupture possibly happening, we are going to do a C-section. Okay, because that is one of the biggest risks, is that because the uterus has been entered before, it could actually rupture because it creates a weakening. Okay, but C-section, a history of miscarriage, so we're going to define that. Okay, a miscarriage is any fetal loss less than 20 weeks gestation. Okay, miscarriage is defined as any fetal loss less than 20 weeks gestation. If you're between 20 and 22 weeks, it's called spontaneous abortion. And if you are more than 22 weeks, it is considered a fetal demise. Those are just clinical terms. Okay, pre or post mature delivery is an indication of, can give you an indication of what to expect from subsequent pregnancies or births. Greater than 37 weeks is considered term. Greater than 42 weeks is considered post-mature or post-dates, and less than 37 weeks is considered premature. Okay, so that baby might not need any intervention, but if they are less than 37 weeks gestation, they are considered premature. Anything over than 37 weeks is considered term, and anything more than 42 weeks is considered post-term or post-mature. Toxemia of pregnancy relates back to that eclampsia and preeclampsia. Okay, so it's development of hypertension with protein in the urine, proteinuria, edema, so swelling, or both. And it usually occurs after 20 weeks gestation. So we went into that a little bit before. Oops, sorry. Maternal diabetes. Okay, we talked about this already. Okay, extra glucose being sent to the baby causes a growth in the fat tissue, but gives you a false sense of security because that baby is born big, but they may have very, very immature lungs because the lungs are developing at the appropriate rate. So a bigger baby isn't always better. And then substance abuse, okay? Alcohol, nicotine, prescription, street drugs, everything the mom ingests, okay? Everything that mom takes into their body, whether it's oral, inhaled, nasal, topical, everything goes to the baby. So if you remember back a year ago when we had pharmacology and we talked about pregnancy risk factors, this is why every drug is assigned a pregnancy risk factor from A, which I've never seen an A, to X. Okay, our normal drugs are B, C. Most of the respiratory drugs are B and C. Okay, B means they're pretty safe. C means use with caution. Okay, and then X means it can do damage to the fetus. Now, when you have a mom come in and you're reading their chart, if you have plenty of time while they're getting ready to deliver, you will always see a pregnancy history report. Okay, and there's two different ones we're going to look at because I've seen them both in the hospital. One is a very simple gravida, para, AB. Okay, so gravida means the number of pregnancies total. Para means the number of pregnancies carried beyond 20 weeks gestation. And then AB is fetal loss before 20 weeks gestation. So if you see a G4 P2 AB2, means that mom was pregnant 4 times total. 2 pregnancies went beyond 20 weeks, 2 pregnancies ended before 20 weeks. It gives you nothing or no information about if they were born alive, if they are still living, how they lost their pregnancy. Okay, it's just that they were pregnant 4 times, 2 went past 20 weeks, 2 ended before 20 weeks. The more detailed pregnancy history is the G5 or GTPAL. Okay, so the GTPAL. So what this stands for is G is still gravida, the number of births or the number of pregnancies that the mom has had, total pregnancies. T is the number of term births. So that means greater than 37 weeks gestation. Okay, regardless of the outcome, regardless of whether they lived or not, that mom carried this many past 37 weeks. P is the number of preterm births. This is before 37 weeks. A is the number of abortions, either elective or miscarriage, doesn't matter. And then L is the number of living children at the time the history is obtained. So this is your example down here. You can see it. G5 is 5 pregnancies. Okay, so that's gravida 5. We have 2 term births, 2 premature births, 1 aborted pregnancy. Doesn't matter how, whether it was spontaneous or elective. And that patient has 4 living children. Okay, that is a more detailed one. So just know that gravida and para means, gravida means how many pregnancies, para means how many deliveries, and then beyond that, it may or may not be more detailed for you to look at. Okay. Another thing that can cause a high-risk pregnancy is maternal infections. Okay, so we're talking about rubella, toxoplasmosis, CMV, herpes, syphilis. All of these things can cause birth defects. So if you break it down, if a mom gets rubella, now rubella, everybody's had a measles, mumps, and rubella vaccine. If this is only possible if the mom hasn't been vaccinated ever, which is, there's more and more of the population that falls into that category, or if their measles, mumps, and rubella is not up to date, because this is one that you have to get boosters for every so many years. If a mom gets rubella while they're pregnant, it can cause severe heart defects in the fetus. Toxoplasmosis. Okay, toxoplasmosis is a parasite spread through fecal matter, usually cats, can also be in undercooked meat. It can cause the fetus to have heart, brain, liver, or other abnormalities. That's why it's super important for pregnant women to not change the cat litter. Herpes. Herpes can be passed to the baby through the vaginal canal. Okay, they can get congenital herpes encephalitis. It is a devastating encephalitis. Any encephalitis is devastating, but that's devastating to a newborn baby. Patients with active herpes, active syphilis, they do C-sections. So they do not pass that on to the baby through the contact. Some maternal anatomic abnormalities that can cause high risk. A small pelvis. Okay, so here's the bottom line. You can't tell by just looking at the woman if they're going to have an anatomic abnormality. This would come from the OB who's done detailed, very detailed or very specific and thorough assessments of this patient. But they have a small pelvis. It could mean that they can't deliver the baby. Okay, they just might not be able to widen, their pelvis might not widen wide enough for the baby's head to come out. That would be a C-section situation. If they have an incompetent cervix, this means the cervix will not stay closed and has to be sewn shut. Usually, this is only detected after a spontaneously aborted baby, okay, where the pregnancy seemed normal and all of a sudden the cervix started dilating and a spontaneous abortion occurred. What they do with patients that they know have an incompetent cervix is they will do what's called a cerclage. And basically they are using a purse string suture to sew the cervix shut. And then when it's close to delivery time, they will cut that purse string and allow dilation to occur. So they can basically sew it shut, not completely, but they can treat an incompetent cervix if they know that that patient has that history. And then uterine malformations, okay, they can have more than one uterus. They can have a misshapen uterus, a heart-shaped uterus. The uterus can have a septum in it. There's just a lot of different abnormalities that when they do an ultrasound, they can usually see that and they can kind of prepare for how they're going to deal with it. Okay, there's many ways to monitor a baby in utero. So we've talked about all the things that can go wrong with the mom and the pregnancy and all that stuff. But there's tons of ways to monitor a baby in utero. And we're going to talk about some of these different ways to monitor the pregnancy. A big one is ultrasound. You know, we all know it's there. It's really cool. We're going to watch a little video, a couple videos on ultrasounds. There's 2D, 3D, and 4D ultrasounds. 2D is a flat picture. Okay, so it's just a picture. They go in there, they scan it. It looks like it's hanging on the wall. They can snap shots of it. 3D is exactly what you think. You know, you can see the 3D image of that baby. It's a delayed image. And then 4D is a 3D real-time picture or video that's actually it's going on right as you're looking at. So it's very cool. You can see the heartbeat, the umbilical cord, the organs, heart chambers, kidneys, and it's accurate at about 13 to 15 weeks, but they usually wait, until about 18 weeks, and they do what they call as an anatomical ultrasound. And they will make sure, because by that time, all the organs are completely formed, so they'll make sure that every organ has what it's supposed to have. So that the heart has 4 chambers, and it has all the vessels that it's supposed to have, and that there's 2 kidneys. So they'll just do these very detailed ultrasounds at around any 16 to 18 weeks, plus or minus 2 weeks for gestational dating. And then they can also do what's called a biophysical profile. Okay, so a biophysical profile takes an ultrasound plus a fetal heart monitor, fetal tone, and amniotic fluid volume, and it puts it into a formula and spits out if things are normal or not normal. Okay, so biophysical profile puts all of this different data together. It's not invasive. It's all done by ultrasound, and it just makes sure that everything's functioning the way it's supposed to be. This video does not have any audio to it, so don't be alarmed.
You're about to be amazed. Thanks to the latest imaging technology, we'll be peeking inside the womb to see how babies grow during the last 7 months before birth, and how they keep themselves busy in the meantime. Now let's see how far our new little person has come in just 8 weeks. The face already has features distinguishable from other babies at the same age, and every day, new features appear that will make this baby's face unique from any other face ever in the history of faces. Another feature unique to each person, fingerprints, are being engraved at the same time. At 9 weeks, our baby learns 4 of the most important things we do our entire lives: sleep, wake up, stretch, and suck our thumbs. Well, maybe 3 things we do our entire lives. While others the same age just shrug their shoulders. Our eyes and nose are 2 of the itchiest parts of our bodies. Fortunately, they take shape about the same time baby learns how to scratch and has fingers to do it with. And baby's mouth can even open to practice saying, "ah," once the itch is gone. At 12 weeks, mom's coughing wakes the baby. Also, without being too specific, a close look will reveal that this baby's parents can stop thinking about girls' names. Also at 12 weeks, baby starts to smile. It's probably just coincidence that this is the same time that baby learns to kick, bend, twist, turn the head, make a fist, and punch. At 13 weeks, sex organs are more apparent, so is bone structure, and vocal cords are close to fully formed, ready to shout out with the first breath of fresh air. Around 4 months, baby can grasp with hands, swim, turn somersaults, and frown. That'll come in handy. The 5th month is when mom and her baby starts communicating. For example, a big noise from outside the womb might be answered by a big kick on the inside. Baby's way of telling mom, "That scared me." There's a growing sense that the mouth is going to be a big deal. Thumb sucking and finger licking becomes serious business. And baby even seems to know that being able to open the mouth will be a useful skill one day. Around week 25, fine hair grows on the head and eyebrows. An average weight is 1.5 pounds, closer to a total of 3 pounds if you happen to be twins, which makes it all a bit cozier. This probably won't be the first time this boy and girl butt heads or lend each other a helping hand in a tight spot. By the way, even though it looks like the twins are sharing the same room, each is in a separate sack, they won't actually touch each other until they're born. In the last 12 weeks, basic training for birth goes into high gear. 2 baby skills are being perfected: grabbing and pouting. Eye teeth are present. And so are eyes. Eyelids do a lot of blinking, even though there's nothing to see. At first, all this new stuff raises a lot of smiles. But after a while, anything can get boring. Even downright distasteful. With just 4 more weeks to go, baby weighs well over 2 pounds, and the once spacious room is getting a little cramped. Except for packing on a few more pounds in the last few weeks, baby's appearance and behavior are pretty much identical to what they'll be at birth. The only major stage of development left is for baby to make the first big decision in its life. When should I get out of here and see if there's anything new and amazing on the other side? Never suspecting that this first big decision will produce the one thing that never stops being new and amazing. the miracle of seeing a new life created by God.
So there's some, oops, I lost you. Here we go. All right, so we talked about amniotic fluid in the previous lecture. So one of the invasive diagnostic tests that we can do is called an amniocentesis. So amniocentesis takes a sample of the amniotic fluid and it analyzes it for chromosome abnormalities, lung maturity. You can tell the sex of the baby, obviously the chromosomes. So it's the most common invasive diagnostic test in pregnancy. It's used most often to identify for genetic birth issues, such as chromosome abnormalities. However, it can be used to determine lung maturity, analyzing amniotic fluid, test for infection, release amniotic fluid from the fetus with polyhydramnios. So that's when that baby has too much amniotic fluid. It's starting to, it doesn't circulate right, so it builds up on the brain, can cause issues with cerebral spinal fluid draining. So they can take or extract some of the amniotic fluid to release some of that pressure. Amniocentesis can be performed between 16 and 18 weeks for chromosome analysis. Okay, if you want to detect lung maturity or for it to be useful for lung maturity, you need to wait till that 24 weeks. So any time between 24 weeks and term, if you take an amniocentesis sample or a sample of the amniotic fluid, you can detect the LS ratio. But before 24 weeks, it isn't really useful for that. Okay, and it shows a picture here. They use ultrasound to guide the needle to make sure that they don't affect the fetus at all. And they'll take a sample of that fluid and then they will analyze it. You can also tell the sex of the baby. We talked about that. It's effective for genetic and the sex of the baby more than 10 weeks, but you really can't tell anything else after that. Not after that, before that. Apologize. Some other ways we monitor the mom. Okay, stress testing, or also known as oxytocin challenge. It tests the ability of the fetus to withstand labor by inducing contractions. Okay, so they'll put a fetal monitor on, they'll give a little bit of oxytocin, induce some contractions, and see how the baby reacts to it. Now, you can see where there might be some risks involved. Maybe the contractions don't stop and the baby, mom goes into premature labor. So it's kind of a cost versus benefit analysis type test. Like, is it really worth the risk? Some other tests that they do on moms, non-stress tests. Okay, so mom goes into the hospital or the doctor's office, they strap on a fetal monitor and they just see for, an hour, 2 hours, whatever. They just watch the baby on the monitor to see how it's reacting to normal life. Okay, they may test the mom's urine by monitoring her urine for estriol. Estriol levels fall 50 to 60% from the previous test. That means it's fetal distress. Okay. Estriol is secreted in high quantities toward the end of pregnancy. So if those levels drop, that means the fetus might be having some distress. They can also do MRIs on pregnant moms. Don't do it very often, especially because we have ultrasound and we have these 4D ultrasounds that we can see everything that's going on. But an MRI is better than an X-ray. Okay, because an X-ray exposes the fetus to radiation. MRI does not. We're going to talk a little bit about Rh positive negative factor or rhesus factors. Okay, rhesus factor indicates the presence or absence of the rhesus protein on the surface of your red blood cell. Okay, you guys have all taken anatomy and physiology. Most of you have actually done this when you were in high school science class. Everybody has either a positive or negative RH factor on their blood type. RH positive moms mean the mom already has the protein, and whether or not the baby is positive or negative doesn't matter. Okay, so my blood type is B positive. I am type B. I have a positive rhesus factor indicated in my blood. So it really didn't matter what blood type my kids were. If a mom is RH negative and the baby is RH positive, it could cause a problem if the mom's blood and the baby's blood come in contact. And that's usually at birth. Okay, there's a possibility their blood could come in contact at birth. Okay, this can cause blood cells to lyse or break down and could result in death. If an RH negative mom is exposed to an RH positive fetus for some possibility, they could reject their pregnancy. Okay, so these RH negative moms get RhoGAM shots. It's a special medication that will help their body to not develop antibodies to the baby's blood. Okay, rejection of the pregnancy does not happen the first time, but subsequent pregnancies are at risk. Right, and here's a little video that kind of animates that.
An individual who is Rh positive should never develop antibodies against the Rh factor. That would be a reaction against self. An individual who is Rh negative can develop antibodies against Rh, but probably won't during their lifetime unless they are exposed to Rh positive blood, correct transfusion. Or this could occur during childbirth when an Rh negative woman carries an Rh positive fetus. While there is no blood exchange at the placenta, during childbirth, blood can be lost and the mother's immune system can encounter the fetal blood cells and thus become sensitized to the Rh factor, and then subsequent pregnancies with Rh positive fetuses would be threatened because in subsequent pregnancies, the mother's body would be capable of reacting against the Rh factor. An individual who is
Okay, so that was just his way of saying it, basically means the same thing. So all mothers get blood tests to make sure whether they're Rh positive or Rh negative. If they are Rh negative, just for safety's sake, they get these RhoGAM shots during pregnancy and then right after they deliver the baby so that they don't develop antibodies to an Rh positive blood type. High risk labor and delivery. Okay, so preterm births. Okay, we're going to talk about what happens in a preterm birth. So labor is considered preterm. We've talked about this, but when contractions occur between 20 and 37 weeks. So remember, everything after 37 weeks is considered term gestation. Contractions are of sufficient frequency and intensity to cause effacement or thinning of the cervix and dilation, okay, widening of the cervix. Preterm delivery occurring after 20 weeks gestation, but prior to 37 weeks, that's considered preterm delivery. Okay, the baby's born early. Remember, if they're not 24 weeks gestation, they probably are not viable. Okay, but it's all considered preterm delivery. It could occur spontaneously or be induced due to maternal or fetal complications. If you have a mom who has severe preeclampsia and their blood pressure is skyrocketing and they are at risk of seizure and stroke, the physician may have to induce labor, okay, regardless of what gestational age the baby is. This is to save the mom. A lot of ethics get involved here, because if the mom doesn't want to be induced and she doesn't want to save herself, then a lot of times this gets into a legal battle, but that's for another day. That's a topic for another day. Survivors of preterm delivery are at increased risk of chronic lung disease, okay, because their lungs are underdeveloped. Vision and hearing deficits. These are all things that happen in the NICU because we have premature babies that we are trying to help physiologically develop outside of the womb in not ideal situations, not ideal environment. Okay, they could get intracranial hemorrhage because the vessels in their brain are not developed and not strong, so they could actually have excess bleeding in their brain. This can lead to cerebral palsy and many other complications. Although it's often difficult to predict preterm delivery, a variety of maternal, obstetric, and fetal characteristics are known to contribute to preterm delivery. The largest predictor is a history of previously having a preterm birth. So those moms are really, really closely monitored. They may have to have more frequent OB visits. They may have to have more frequent screening of the pregnancy, more frequent ultrasounds. They may have to have more invasive ultrasounds, okay? So all of those things just to really make sure that that pregnancy is carried to term. A cervical length of 25 millimeters or shorter, measured with a transvaginal ultrasound. So this is an ultrasound wand that actually goes into the vagina. And it gives you a very close and detailed view of not only the cervix, but you can also get a really close view of the fetus. They'll do that on a regular basis for high-risk pregnancies. Okay, extreme prematurity lists all the things that can happen. Okay, risk for chronic lung disease, I said that. Vision deficits, okay, some of them may have to have eye surgeries, hearing loss, intracranial hemorrhage, learning disabilities, very low birth weight infants. Okay, all of these things can happen for preterm birth or when you have a preterm birth. Some symptoms of preterm birth, obviously uterine cramping or contractions, increase in vaginal discharge, whether it's watery, bloody, or a mucus plug, increased vaginal pressure and sensation, and low backache. Often preterm labor, like when moms are having back pain, like back pain is normal in pregnancy. Like I can tell you, back pain, I have chronic back pain anyways, but then pregnancy always makes it worse because your body's changing and your weight distribution's off. But if they're having a low backache and it's constant and continual, or it's actually present and then absent and then present, well, that's a contraction. Okay, so that's a symptom of preterm labor. Management of preterm labor, okay, always assessment of medical history, evaluation of these clinical symptoms, all these things that they're listing over here. And then some things they can do to prevent early delivery or stop labor. One of the big ones is tocolytic therapy or medication therapy. Mag sulfate is one of those medications. It is actually a smooth muscle relaxer. So it is a beta agonist, but it affects or works right on the uterine smooth muscle. Believe it or not, uterine smooth muscle has beta 2 receptors in it. So that's one of those places where mag sulfate works really well. Terbutaline was another one that used to be used to stop labor, and it reduces smooth muscle contractility and helps relax it. If we can relax the smooth muscle, we can possibly stop labor. And these are some other drugs that can be given. The problem is when these drugs are given, it also causes a decreased respiratory drive in those patients. So often if the mom is on mag sulfate and the baby's born, they're very sleepy and they don't want to breathe. So we have to, if we know they're on mag sulfate, we can prepare for that to have a little more robust resuscitation for that baby. Multiple gestation, you just have to make sure that you have all the equipment ready for more than one baby to be born. Post-term pregnancies, contributing factors, prior post-term pregnancy. So I will tell you, like all 3 of my babies would have come late. My middle one I was induced with, but all three of my pregnancies, I don't know, must have a very inviting environment because none of them wanted to be born. Maternal obesity can contribute to post-term birth, increasing maternal age, and nulliparity, which is the term used to describe a woman who has never delivered a child. So, and they themselves were post-term. So it's kind of like a genetic, like my mom had me, I was post-term, then my kids were all post-term. So it's kind of like, it's just a genetic trait carried down that your babies don't want to be born or you don't go into labor on time. So placental disorders, okay, this, again, high-risk pregnancies, we need to talk about the placenta. One of the big things is how the placenta is implanted in the uterus. Okay, where is it located? Where did it actually affix itself to the uterus? When the placenta is not adhered or affixed in the uterus in the right place, it's called placenta previa. And I'm going to go to the next slide because I think these are out of order. But there's two different types of placenta previa we're going to talk about. Okay, so here's the normal where the placenta should be implanted. It should be high in the uterus, high and away from the cervix. If you have a low-lying placenta, so it's adhered to the uterus in a low position, it's not necessarily super detrimental, okay? But once the cervix starts to dilate, it could detach and it could be expelled prior to the baby. Okay, and then that's low-lying placenta. And then placenta previa is when the placenta is completely under the head. So like the baby's head's resting right on the placenta. The placenta is completely covering the cervix. So when the cervix does thin this way and dilate, get wider, that placenta will detach prior to the baby being born and could cause a hemorrhage and could cause fetal death or fetal harm. So maternal complications of placenta previa, hemorrhage, preterm delivery. If they hemorrhage, they can go into shock. It could also cause blood clots, infection, or death for the mom. For the fetus, depending on how the baby's head is engaged or how the baby's head is lying where the placenta is, because remember, all of the nutrients, the oxygen, everything's exchanged at the placental level. So if that placenta is not positioned in a place where it can function optimally, but it's positioned low or super low, and it could get compressed, then that gas exchange, the exchange of nutrients, exchange of hormones, exchange of whatever is exchanging between the placenta for the baby and the mom, then something's going to suffer. Okay, so in this instance and in this instance, low-lying and placenta previa, it could cause compression on the placenta and it might not function the way it's supposed to. So insufficient blood supply to the fetus, intrauterine growth retardation or restriction, which means, they're not getting the nutrients they need, not getting the oxygen they need. Hypoxia could cause anemia and it could cause fetal death. So all these things are complications of placenta previa. The other high-risk placental disorder is called placental abruption. Okay, so abruption means the placenta tears away from the uterine wall. It causes a hemorrhage, okay, and it causes blood loss for the mom and for the baby, and can result in fetal death. Okay, so this next slide shows pictures of, this is the normal placenta. Okay, so here's your baby, placenta is attached to the uterine wall. Usually it's even a little bit higher, but in this picture, you can see it's kind of on the side. Next picture, you have a partial placental abruption. Or this picture over here, sorry. Partial placental abruption. So it's partially torn away, but the edges of the placenta are holding that blood in place. So it's a concealed hemorrhage. This picture right here is a complete placental abruption. Okay, the placenta is torn away from the uterine wall you have active bleeding. These are the patients that say, I went to the bathroom, I felt a sharp pain, and the toilet filled with blood. That is a medical emergency, because if the placenta tears away from the uterine wall, that means there's no longer any communication between mom circulation and fetal circulation, and that baby is being asphyxiated. Okay, that is a medical emergency, and that has to be taken care of immediately, or the baby will not live, and it causes a high risk to the mom as well.
Placental abruption. Under certain abnormal conditions, bleeding can occur between the uterus and placenta. This is called a placental abruption. With an abruption, oxygen delivery is reduced. Until 25% of the placental uterine interface is affected, oxygen delivery to the baby is not significantly impaired, and the baby will be able to compensate. The signs of an abruption include bleeding, abdominal pain, hypertension or increased blood pressure, and uterine irritability. The abruption can continue to expand as the bleeding worsens. And vaginal bleeding can be seen. As the abruption continues, the surface available for oxygen transfer is reduced. And maternal blood loss can affect the mother by causing dehydration and eventually lowering her blood pressure, leading to decreased oxygen delivery to the baby. Until the abruption reaches a dangerous level, the baby can continue to compensate by increasing her heart rate. When a mother presents with the classic presentation of a placental abruption, she must be immediately assessed and a diagnosis of abruption be ruled out with an ultrasound. Without proper intervention, the blood loss can lower the mother's blood pressure, leading to decreased oxygen delivery to the baby. If the abruption is not diagnosed in a timely fashion and the baby delivered, prolonged oxygen deprivation can lead to permanent injury to the fetal organs, including the brain.
All right. So that's placental disorders. Okay, we have placenta previa, when the placenta is not attached in the uterus where it's supposed to. It should be high up in the uterus. You have low-lying placenta, and then complete placenta previa is when it's covering the cervix. And then we have placental abruption. And when the placenta tears away from the uterine wall prematurely and causes bleeding. It can be partial or it can be complete. A partial placental abruption, you'll see bleeding, but that fetus is not at risk immediately, but it needs to be dealt with, okay? A complete abruption means that all connection between the mom and the fetal circulation has been disrupted and could cause fetal death. Umbilical cord disorders. So we talked about every umbilical cord has one umbilical vein, two umbilical arteries. Well, that's not exactly true because you can have a two-vessel cord. Two-vessel cord can be an indication of organ abnormalities and chromosomal abnormalities. However, it doesn't have to be. One of the professors that used to teach in this program, who now teaches at Apollo, she's the anatomy professor at Apollo. She had a daughter that was born with a two-vessel cord. Her daughter was fine. There was nothing wrong. It's just that she only had one artery instead of two. But usually you have three vessels, one large vein, two smaller arteries that wind around that vein, looking kind of like this down here. Next one we're going to talk about, and this one is actually super risky, is called cord prolapse. Now, what happens when the cord prolapses is the cord is developed, the umbilical cord is delivered through the cervix before the head is. Okay, and then what happens is when the cord's delivered through before the head and the head engages, it will pinch the umbilical cord off. What is providing oxygen to the baby? The umbilical cord. Okay, so when that umbilical cord is pinched off, what is not getting to the baby? Oxygen. Okay, so a undiagnosed or an untreated umbilical cord prolapse can lead to hypoxic ischemic issues. Hypoxic ischemic encephalopathy, which means lack of oxygen to the brain. It can lead to fetal death. Okay, I have seen cord prolapses before, and the way they are most often treated, if the head is not completely engaged or out, they will push that baby back in and relieve the pressure off the cord, and there will be an emergency C-section. Okay, fetal bradycardia is an indication of a prolapsed cord because you can't always see it. Okay, so sometimes the head engages in the pelvis and it's pinching off the cord, but you still can't see the cord. So if you have a rapid fetal bradycardia, it's an indication of a prolapsed cord. Nuchal cord means cord around the neck. Now, I want to take a second and talk about this because umbilical cord wrapped around the neck happens in 30% of all births. Okay, it may be suspected prior to delivery if you have some fetal heart decelerations, but having the umbilical cord wrapped around the neck is not what causes fetal death. Okay, pinching off that umbilical cord, kinking it, knotting it, if it's around the neck and it's so tight that it pinches off the vessels, that is what causes the lack of oxygen. Okay, because remember, the mom is supplying all the oxygen to the baby. Okay, until that cord is clamped, kinked, or cut, the lungs are not working to provide oxygen to the baby. So the physician, yes, he wants to get the cord from around the neck, but it's more to make sure that it doesn't kink or knot or for some reason get obstructed so that blood flow is not happening. Now, after the cord is cut, you obviously need to have open airway, open passage. But people often think that the reason, you know, babies asphyxiate is because the cord was around their neck. Well, it's because the cord is clamped for some reason. So you just have to be very careful to make sure that that cord is free and open and still can provide blood flow until you clamp it off. We're going to talk a little bit about twin-to-twin transfusion because you may see patients, especially when you go to the neonatal intensive care, that have this. Okay, so twin to twin transfusion means there's a blood supply abnormality between the two twins. Okay, the donor twin is giving extra blood supply to the recipient twin. So the donor twin is actually has less nutrients, they're anemic, they're growth restricted, they have risk for bone contractures, pulmonary hypoplasia, or underdeveloped and stiff lungs. And then the recipient twin receives an excess of the blood supply, which then causes polyhydramnios or extra fluid, especially through the neurological system. They are at risk for developing heart failure and a condition called hydrops, which can cause kidney damage, brain damage, and death of one or both twins. This is most common in identical twins, but can happen in fraternal twins. It's very rare, but I actually know someone that this happened to. So twin to twin transfusion just means that the circulation of blood, one twin is getting extra, the other one is getting not enough or less. Labor and delivery, there's some things that can occur or some things go wrong, abnormal things happen that can cause for a high-risk delivery. One of them is called meconium in the amniotic fluid. Meconium is the baby's first stool that passes through their intestines. A meconium is comprised of skin cells, acid, salt. It's very thick. It is very sticky and tar-like. And it usually happens when the baby is stressed. Okay, so if oxygen is reduced to the baby and the baby becomes stressed, they can pass meconium into their amniotic fluid. Post-term babies very often will have passed their meconium into their amniotic fluid. What is the problem with this other than the baby being born covered in meconium? Okay, when that baby comes out and the cord is clamped, we want them to gasp and take a big deep breath to fill their lungs. If they are covered in meconium and there's meconium in their mouth, which they've been practice breathing this amniotic fluid, correct? So if there's meconium in the amniotic fluid, chances are it's in their mouth and maybe even a little bit in their airway. They gasp and take a big deep breath, it's going to get sucked right down into their lungs. If meconium gets sucked right down into their lungs, it forms thick, sticky ball valve effect. So it's clogging the airways with this thick, sticky, maybe acidic substance. Okay. Usually what happens is they can take a deep breath in. So it's a ball valve. Take a deep breath in, and when they try to exhale, it traps air. It also causes toxic, it can cause toxic response in the lungs. They can get meconium aspiration syndrome, which ends up being a lot like ARDS. And these babies are very, very, very sick. The good news is that if we identify it early when the water is broken and the amniotic fluid flows out, if you see it's meconium stain, you can kind of prepare to be able to treat that baby if necessary. Some other things can go wrong during delivery, such as abnormal presentation, okay? These are called breech presentations. It's when the baby is head up instead of head down. Okay, a frank breech means that they are butt first into the birth canal. Complete breech means that they are kind of sitting, you'd say crisscross applesauce or Indian style, however you want to say it. That's a complete breech. Feet are down, butt is down, head is up. And then footling breech, this happens a lot with our premature infants, where the mom comes in and you go to examine her and there's a little foot hanging out of the vagina. So different presentations, these are all breech, but frank, means their feet are up by their head, complete, butt down, feet down, and footling means the feet are coming out first. Here's a little picture of it, what they call an external version, where they try to actually turn the baby so they're head down from the outside. I have friends that have had these external versions before. They're very, very painful. You always hope that the baby turns on their own, but it doesn't always happen that way. Other things that can go wrong during pregnancy. Okay, a variety of things can go wrong. One is prolonged rupture of membranes. So what this is talking about is when you have a leak in the amniotic sac and the mom is leaking amniotic fluid. Anytime amniotic fluid can get out, bacteria or viruses can get in. This can cause an infection throughout the whole amniotic sac, the chorion. Infection in that area is called chorioamnitis. When the membranes rupture or the patient's water breaks, you will smell foul smelling liquid. It's usually accompanied by a fever, maybe abdominal pain. This baby can be born sick as well as the mom being sick. Okay, so the infection reaches the uterus and the fetus. It's pretty serious. So anytime you have a mom say, well, my water broke, but the liquid smelled really foul, it was discolored, you need to prepare for a sick baby. So again, anytime fluid can leak out, bacteria, viruses can leak in or can creep in. Some antenatal monitoring, so fetal heart rate monitoring. We have these external heart rate monitors. They assess fetal well-being during pregnancy, labor, and delivery. Okay, very, very common. They're used for those non-stress tests. They're used for stress tests. All different kinds of electronic fetal monitoring, just to make sure that the baby's heart rate is good. A variety of things can go wrong or make delivery more difficult, and fetal heart rate decelerations are one. Okay, so anytime that baby, when a contraction occurs, it could actually put pressure on the cord and decrease the amount of oxygen being delivered to the baby. This can cause the heart rate to go down. Okay, many times moms will be put on oxygen just to deliver a little bit of extra oxygen to them. It'll increase fetal O2 and it'll help stabilize the baby while you're monitoring them. And the last thing we're going to talk about in this section, we're going to talk about cervical effacement and dilation. You're going to hear these terms all the time. Effacement means thinning, okay, thinning of the cervix. This is 0% effaced, okay, so we have a nice thick cervix, it's holding that baby where it's supposed to be. 50% effaced means it's thin to 50%, and 100% effaced means that the cervix is ready to open up, it's completely thin. Dilation, and here's some pictures for you to look at, but this kind of gives you an indication of, 1 to 10 centimeters. 10 centimeters is considered completely dilated and the baby's head is ready to be delivered. 1 centimeter is like a Cheerio. 3 is like a slice of banana. 4 is like your Ritz cracker. 7 is a soda can, and a normal sized bagel is 10 centimeters dilated. They'll usually check that. They have specific little measuring devices. A lot of labor and delivery nurses and OBs have done it long enough that they can just check it with their fingers and they can tell you how far dilated you are. So they're very experienced and know what they're doing. Now, the last couple things we're going to watch, I'm going to throw some videos on about labor and delivery, effacement and dilation, and then we're going to watch a vaginal delivery, C-section, and a breech delivery. So, just wanted to prepare you for what was coming.
I found, Baby Center as a really big resource for me, almost like a friend.
It follows me all the way clear back through preconception, pregnancy, through delivery, through new mommyhood.
In the weeks before birth, your body slows down production of the hormone progesterone while increasing production of other hormones, including prostaglandins, which soften the cervix, and oxytocin, which triggers the uterine muscles to contract. True labor contractions are rhythmic and painful and grow consistently stronger. As the long vertical muscle bands of the uterus tighten, they pull the cervix open. The strong muscles at the top of the uterus push down and release, guiding your baby toward the cervix. The mucus plug, a collection of thickened cervical mucus that sealed your cervix shut for 9 months, may be expelled days before or in the midst of labor. When the amniotic sac ruptures, your water has broken. It can feel like a trickle or a gush of fluid. Your cervix will begin opening and thinning, known as dilation and effacement. Once you reach about 4 centimeters, your body will move into active labor. In active labor, contractions become stronger and closer together. At 8 centimeters, you enter what many consider the most painful part of labor, transition. By 10 centimeters, you're fully dilated and may feel the urge to push. This is your signal that the second stage of labor has begun. Your baby will move down with each contraction. The 3 separate soft bones of his head will temporarily overlap so he can pass through the snug birth canal. Your baby's scalp will come into view. When the widest part of his head is visible, your baby is crowning. With several more pushes, your baby's face, shoulders, and body will emerge. In the third and final stage of labor, your placenta detaches and is expelled. With your baby's first breath, the incredible journey of birth is complete.
Sherrod Brown knows how hard we work. He fought to cap the cost of insulin for Medicare recipients at $35 and to lower the cost of prescription drugs and insurance premiums. Tell Sherrod Brown, keep fighting to lower costs.
During a vaginal childbirth, the first stage of labor lasts about 12 to 19 hours and starts when your baby settles lower into your pelvis. In response, your cervix begins to efface or become thinner and dilate or widen. During this time, you may feel strong, regular contractions occurring every 5 to 20 minutes, and lower back pain and cramping that doesn't go away. You may see a brownish or reddish mucus discharge, which could be the mucus plug at the opening of your cervix, falling out. Your water may break, which can either be a large gush of fluid or a continuous trickle. If you experience any of these symptoms, contact your doctor or midwife to see if you should go to the hospital. At the beginning of stage 2 of labor, which usually lasts from 20 minutes to 2 hours, your cervix is fully dilated to 10 centimeters, and your baby's head has moved beyond the cervical opening into your birth canal. Your doctor or midwife will instruct you to push during your contractions and rest between them. In a normal delivery, your baby's head will rotate to face your back. During active labor, your uterus is divided into an active segment that contracts, pushing the baby downward, and a flexible passive segment that remains relaxed, stretching to provide more room for the baby to pass through. When the top of your baby's head appears, or crowns, your doctor may make a small cut, called an episiotomy, to enlarge the vaginal opening. Then, your doctor or midwife will give you instructions on how to push your baby out. As your baby's head passes through the birth canal, it molds into an elongated shape. An elongated head shape will resolve itself within a few days as the skull bones shift back into place. After your baby's head exits the birth canal, his or her head and shoulders will rotate to help the shoulders pass through the birth canal. Your baby's shoulders are delivered one after the other in order to fit through your pelvis. Once the shoulders emerge, the rest of your baby slides out easily. After your baby is born, his or her umbilical cord will be cut. In stage 3 of labor, which may last 5 to 30 minutes, mild contractions will help push the placenta out of the uterus. During this stage, you and your baby may begin bonding through skin-to-skin contact and breastfeeding.
లైట్ అడ్జస్ట్ చేసుకోండి. ఏది ఫిజియోథెరపీ పర్వాలా ఉంది. अच्छा सांस लो लंबे लंबे. अच्छा था ना तो डोंट टच करो बोले तुम. Bulging bladder. Bulging bladder. यूज है
All right, I have one more for you guys to watch. This is a breech delivery, so pay attention to this one, and then the lecture will be over.
Push. I'm gonna push for 5 more seconds. 5, 4.
3, 2, 1,
Okay, the next contraction should be about 20 seconds.
I can't push anymore. I can't.
You're doing great.
Oh, God, 20 seconds more, yes!
Here we go. Okay, keep pushing.
Come on,
Push. Wait. I see something.
What, you do? You do? Oh my God!
Don't say, oh my God, what?
What is that?
It's the baby's buttocks. She's breech.
Oh my God, I thought she had 2 heads.
Is she gonna be okay?
She's gonna be fine. Okay. She's in a more difficult position, so you're gonna have to push even harder now. Go. Push. Push. Rachel, you're gonna have to push even harder. Nothing's happening.
I'm sorry, I can't.
Yes, you can. Hey, come on, you can. I want final push. Ready? 1, 2, 3. Keep pushing!
Are you okay?
You have no idea how much this hurts. Keep going! Keep going!
Here we go.
Oh, she's upside down, but she's coming. She's coming.
Oh, God.
Oh my God. Oh my God, she's here. Oh, she's perfect. Oh.
Oh, she's so tiny.
All right, I know that was a clip you guys have probably seen before, but thought it was kind of a good way to end this. So, that was the end of the 3rd lecture. We've gone all the way through labor and delivery. We've talked about fetal lung development, fetal circulation, changes between fetal circulation and adult circulation, what structures are present, what structures disappear, how that all happens. We've talked about maternal history, how it plays into how we're going to treat patients. And when we have lab next week, we're going to be doing 3 things. We're going to be doing some activities that help us to learn fetal circulation and fetal lung development. Stuff that'll help kind of solidify it in your mind, at least I hope so. It's worked in the past. And then we're going to be dividing into groups and going down and birthing babies with Mr. Harris. So he's going to be walking you through all the stuff that we talked about today. If you have any questions, email me. Have a great week, and I'll see you a little bit tomorrow online.